At roughly 4 weeks of embryonic development, the tissue that will become the human head and neck begins an intense period of organization. The undifferentiated mass develops a highly specific, segmented scaffold. This foundational blueprint is the pharyngeal apparatus. It is a strictly ordered system composed of 4 main elements: arches, pouches, external clefts or grooves, and the membranes that separate them. This diagram illustrates the spatial formation of the pharyngeal arches. They develop directly in the lateral wall of the primitive pharynx and extend ventrally, eventually fusing with their counterparts in the floor of the pharynx to form horseshoe-shaped cylindrical bars. Notice the numbering of this initial sequence. 6 arches appear during early development, but the 5th arch is completely rudimentary and rapidly disappears, leaving behind functional arches 1 through 4 and arch 6. The adult structures of the head and neck are not randomly distributed. Their final position, function, and innervation are rigidly dictated by exactly where they originate within this temporary 6-part embryonic scaffold. To understand what these arches produce, we have to look at their internal composition. Each arch features a mesenchymal core. This core is formed partly by primary mesenchyme, but the major component is secondary mesenchyme, which originates from migrating neural crest cells. This core is then sandwiched between 2 distinct cellular layers. The external surface is lined by ectoderm, while the internal surface is covered by endoderm. For the musculature in this region, a general rule applies. Myoblasts derived from unsegmented paraaxial mesoderm and the precordial plate migrate into the arches. These cells eventually form the muscles of mastication, facial expression, the pharynx, and the larynx. The extrinsic muscles of the eye bypass this system entirely. They derive from mesenchymal cells near the precordial plate, specifically from 3 preotic myotomes. Because of this distinct origin, each myotome brings its own specific nerve supply: cranial nerves 3, 4, and 6. Identifying whether a specific tissue stems from the endoderm, the ectoderm, or the mesenchymal core provides the only reliable roadmap for predicting its final anatomical destination and its lifelong nerve supply. We begin with the first pharyngeal arch, which divides into the maxillary and mandibular processes. Its designated nerve is the mandibular branch of the trigeminal nerve, or cranial nerve V3. Looking at this schematic of the pharyngeal arch cartilages, we can trace the skeletal derivatives of the first arch. Originating from quadrate and Meckel's cartilage, this arch forms the maxilla, the mandible, the incus, the malleus, the anterior ligament of the malleus, and the sphenomandibular ligament. The mesoderm of the first arch produces a highly specific set of muscles. These include the tensor tympani, the tensor veli palatini, the muscles of mastication, the mylohyoid, and the anterior belly of the digastric. To complete the first arch inventory, we must add the tissue that will become the anterior 2/3 of the tongue and a transitory vascular component, the maxillary artery. Moving further down the apparatus to the second arch, the designated cranial nerve now shifts to the facial nerve, cranial nerve 7. The skeletal derivatives here originate from Reichert's cartilage. They include the stapes of the middle ear, the styloid process, the stylohyoid ligament, and the lesser horn and upper body of the hyoid bone. The muscle and vascular derivatives of the second arch follow a similar logical grouping. They yield the stapedius, the stylohyoid, all muscles of facial expression, the posterior belly of the digastric, and the transitory stapedial and hyoid arteries. All adult structures responsible for foundational biting originate from arch 1, and those responsible for facial expression come from arch 2. Because of this, they permanently carry their respective cranial nerves, V3 and V7, with them, regardless of where they eventually migrate in the mature head. This brings us to the third arch, innervated by the glossopharyngeal nerve, cranial nerve 9. Its skeletal contribution is strictly limited to the greater horn and the lower part of the body of the hyoid bone. The third arch also directly provides the stylopharyngeus muscle, the tissue for the posterior 1/3 and root of the tongue, and crucial vascular structures, the common and internal carotid arteries. This introduces a strict embryological rule and its singular exception. The vast majority of pharyngeal muscles are derived from the fourth arch. The stylopharyngeus is the only pharyngeal muscle that derives from the third arch. The fourth arch is innervated by the superior laryngeal branch of the vagus nerve, CN10. It forms the important thyroid and epiglottis cartilages, alongside the proximal right subclavian artery and the arch of the aorta. Another strict rule appears here. The fourth arch forms the muscles of the palate and pharynx, plus the cricothyroid muscle. While almost all laryngeal muscles develop from the sixth arch, the cricothyroid is the exception. Finally, the sixth arch is innervated by the recurrent laryngeal branch of cranial nerve 10. It produces the remaining laryngeal cartilages, the cricoid, arytenoid, cuneiform, and corniculate, as well as all the remaining laryngeal muscles, the pulmonary arteries, and the ductus arteriosus. As we map the tissues deeper down the pharynx, from arches 3 through 6, the structures predictably transition away from mastication and facial expression, focusing entirely on swallowing, airway protection, and forming the major aortic vessels. Returning to the inner layers, this illustration shows the internal endodermal lining of the pharyngeal apparatus. This endoderm balloons outward into the surrounding mesenchyme, forming distinct cavities known as the pharyngeal pouches. Pouch 1 extends far outward to form the epithelium of the middle ear cavity and the eustachian, or auditory tube. Pouch 2 undergoes a more complex process. Its endoderm proliferates rapidly into the underlying secondary mesenchyme. The central parts of these buds break down to form the palatine tonsil crypts. By 20 weeks, the surrounding mesenchyme differentiates into organized lymphoid tissue, leaving behind a visible remnant known as the supratonsillar cleft. Pouch 3 divides into two functional sections. The ventral portion forms the thymus, while the dorsal portion forms the inferior parathyroid gland. Pouch 4 also splits. Its dorsal portion yields the superior parathyroid gland, and its ventral structure, the ultimobranchial body, develops into the parafollicular C cells of the thyroid. Notice the physical inversion in this migration map. The structures originating from pouch 3, the thymus and the inferior parathyroids, actually descend much further down into the neck and chest than the superior parathyroids, which originate from the anatomically lower pouch 4. We turn our attention now to the outer shell. The ectodermal lining indents to form pharyngeal clefts, also known as grooves. Where a cleft meets an internal pouch, a thin layer is formed, known as a pharyngeal membrane. This diagram shows the only adult derivatives that survive from these outer structures. The first cleft forms the epithelium of the external auditory meatus, and the first membrane forms the tympanic membrane itself. The remaining clefts are physically buried. The mesenchyme of the second arch experiences a massive downward growth spurt. It rapidly overlaps clefts 2, 3, and 4, eventually fusing below with the epicardial ridge. This overgrowth traps the lower clefts beneath the surface, creating a temporary slit-like cavity lined with ectoderm called the cervical sinus. Under normal developmental conditions, this sinus will completely obliterate and disappear. This rapid folding and subsequent destruction of the cervical sinus is a high-risk structural maneuver. If the obliteration process is somehow incomplete, the resulting void leaves a permanent physical defect in the patient's adult neck. The clinical necessity of understanding this embryonic wrap becomes clear when we examine what happens when the cervical sinus fails to disappear. The result is the formation of a branchial cyst. This illustration demonstrates exactly where a branchial cyst will present based on its embryonic origin. It appears at the anterior border of the sternocleidomastoid muscle, at the junction of its upper 1/3 and lower 2/3, positioned just below and behind the angle of the mandible. In some cases, this cyst maintains an opening to the surface of the neck, known as an external branchial sinus. Rarely, it may communicate internally directly with the tonsillar fossa, forming an internal branchial sinus. A more complex anomaly is a branchial fistula. This develops due to the rupture of the membrane separating the second pharyngeal cleft from the second pharyngeal pouch. Surgical correction of a branchial fistula requires routing a path perfectly between the external and internal carotid arteries. This exact anatomical trajectory is dictated entirely by the ancient embryonic layout of the second pouch and cleft. Beyond localized structural defects, failures within the pharyngeal apparatus can trigger systemic collapse. The clearest example is DiGeorge syndrome, caused by a deletion on chromosome 22q11. The core defect in DiGeorge syndrome is impaired neural crest cell migration. Without this vital delivery, pharyngeal pouches 3 and 4 fail to develop correctly. The resulting clinical triad maps directly to the structures we outlined. Patients lack mature T cells due to thymic hypoplasia, making them susceptible to recurrent infections. They suffer hypocalcemic tetany and seizures due to missing parathyroid glands, and present with distinct mandibular hypoplasia. Crucially, because these same migrating neural crest cells are required to form the cardiac outflow tracts, derivatives associated with the sixth arch, the most common cause of death in these patients is cardiovascular defects. By tracing adult head and neck structures back to their origins in the arches, pouches, or clefts, seemingly chaotic anatomy transforms into a highly predictable, logical, and clinically vital system. Special thanks to Dr. Vikrant Tripathi, Associate Professor of Human Anatomy at University College of Homeopathy, DSRRAAU Jodhpur, for his contributions to the academic framework of this video.